Well, welcome to another episode of the award-winning radio show and podcast, Dr. Doctor, featuring your host, Dr. Chris Stroud.
And Dr. Andrew Mullally, where we and our guests discuss relevant and health-related topics from an authentically Catholic perspective.
Today, our guest will be heard across the EWTN Global Catholic Radio Network. And joining us again, listeners will recognize pediatrician extraordinary Dr. Gwyneth Spaeder. She's going to talk about adolescent medicine. I can't think of a more important topic today.
Yeah, a lot of heavy stuff in this episode, so maybe a little warning for any younger kids who might be listening. But for parents, you're not going to want to miss it. We're going to go straight to the interview so we have time for all of the important questions. We'll be back in just a moment here on Dr. Doctor. All right, and we are back today on Dr. Doctor with Dr. Gwyneth Spaeder of happy memory. It's not your first time, not your first rodeo here. Listeners will remember that Dr. Spaeder went to University of Dallas for undergraduate and got a degree in political philosophy before going to Johns Hopkins for School of Medicine, and is now a pediatrician in Wake Forest, North Carolina, where she lives with her husband and 3 children. So, Gwyneth, thank you for coming back on to talk about a very important topic.
It's my pleasure. Thank you so much for having me.
So, as we talked about in the intro, with another episode with Gwyneth, we talked about infants and newborns and sort of the traditional schedule of care and what happens and why it happens. We're going to continue that discussion talking about adolescence. And so, it's hard to pick what's most important or most controversial about adolescents. They're not easy little critters sometimes.
No, they are not.
I kind of think this might be the most complicated topic to talk about in relation to pediatrics. I don't know if that's true or not, but it's there's so many things, and I would say, especially with the guidance that we get from professional organizations such as the American Academy of Pediatrics, how that is juxtaposed with what common sense and maybe our faith would tell us is the best way to care for these youngsters. So
yeah, I think you're exactly right. I mean, there are days in my office when I, just because of the way my schedule works out, that I'm bouncing between, a 2-month-old and a 16-year-old and a 4-year-old and an 18-year-old. And it's almost, you get a little bit of whiplash in how much variety there is in day-to-day pediatric life. But I think adolescents are a remarkable population to take care of for the same reason that they're a remarkable population to parent. And that is that there's so much growth and there's so much development, and it's exciting and it's fun to watch, but there's challenges that go along with that as they're trying to figure out who they are and who they want to be. And that comes out very clearly in the pediatrician's office.
I've heard it said about anesthesia that it's, as a practice of anesthesia, it's 90% boredom and 10% terror. and I would say maybe there's an analogy there for parenting adolescents.
Yeah.
You cruise along pretty smoothly for a while, and then all of a sudden, you're not.
Yes, I think that's accurate.
And I remember from my peds professor in medical school, he used to always say, children are not just little adults, they're not just adults with lower doses of medicines. But it seems to me that couldn't be more true with adolescents. They're not just young adults, are they?
They're really not. I mean, interestingly, I'm very familiar with that phrase. They're not just little adults. We tell it to our students all the time. But it's in the physical aspect of the field of pediatrics, that's probably more true when you are dealing with the very young ages, and some of their physiology is very different than adult physiology. By the time you're dealing with adolescents, the physical differences between them and adults start to shrink. And in terms of biology and pharmacology, a lot of those differences go away. But in terms of psychology and mental health and just overall maturity and intellectual development, they are very much not adults yet.
Well, Gwyneth, maybe we can launch right into the idea of the whole well-child checks. I feel like a lot of parents are really on board when they've got a newborn and they're scared to death and they don't know what to do. And then they go for a couple, 5, 10 years. And then, it's kind of routine, especially if you have a couple of children. And then you get to the adolescent years. Why is it important that they have well-child checks?
Yeah, I think it's a great question. I think you're right. A lot of parents assume by the time their kids kind of hit middle school and get their first round of booster shots that they're good to go unless something comes up. The reason we encourage families and patients to continue to come and see us yearly is very similar for the reasons we talked about at the last podcast. You know, we are trying from an objective perspective to keep an eye on their growth, both their physical growth and kind of emotional and intellectual growth, and make sure that that's proceeding appropriately. And then again, we are kind of trained to catch things, either physical or emotional or mental, that might not be obvious to the parents, that are a developing problem, that the sooner we intervene, the better. You know, a lot of parents have very fuzzy memories of their own experience going through puberty, and they might not actually know what's normal progression and what's not. Scoliosis is something, or curvature of the spine, is most common to develop in early adolescence when you're going through your growth spurts. So critical to have regular screenings of that. And then I also like to try and explain to families that adolescents need to start learning to take ownership of their own health. That while I very much want their parents to be involved with the discussions that we're having, that, you know, by the time they graduate from my care, they need to be able to advocate for their own health. And part of learning how to do that can occur in these adolescent visits.
Well, I guess one question that comes up sometimes is the idea of the well-child check versus maybe the sports physical, which I feel like sometimes they occur on the same day. What are some of the similarities and differences there?
Yeah, I think that's a good question. I mean, in my practice, we basically treat them interchangeably. So if you have had what we call a well-child check or an annual physical, we will fill out a sports clearance form as long as that visit has occurred within a calendar year. The reason there's been so much emphasis on sports physicals in the past, I don't know how many years, is that we are trying to reduce the risk of significant injury or harm to any of our patients who are playing in various sports teams. So we're primarily trying to catch cardiac risk, but we're also looking for the possibility of neurologic injury, musculoskeletal injury. And some patients, whether it be their own health history or their family's health history, are at higher risk of having one of these bad outcomes from sports play. So the sports physicals, at least in the state of North Carolina where I practice, start with a screening questionnaire that asks very specific questions about the patient's own health history and the immediate family's health history. And then after that, it's just a regular physical exam that we sign off on. So, you know, I don't know how different states handle this, and I do believe in the importance of a sports physical, but I'm happy to wrap it into a well-child visit. But I would say a well-child visit is a more thorough look at the overall health and development of the child, whereas a sports physical is really focused on making sure that we're not overlooking an inherent risk to playing sports.
You know, right after COVID, when that all went through, something really controversial, at least in my state, they made sports physicals not required. And so what we saw subsequently was a lot of folks who really skipped a year or two of any kind of well care whatsoever. Did you guys see that where you're at?
We did not, and I saw that on the list of questions prior to this podcast, and I was actually a little bit surprised by it. So local to where I practice, there was only a very short period of time when we stopped what we considered, quote, non-essential physicals. So we never stopped seeing kids who were due for vaccines. And there was only a few month period where we were trying to delay the other annual physicals in the other age groups. So there was never an instance in which somebody would not have been able to get a sports physical. The other component to that is that our public school system was closed for a year and a half here, and so there weren't a lot of sports going on.
Sure.
And so there weren't a lot of people asking for sports physicals. But as a general topic or thought experiment, I think you're exactly right to point out that when we do things like that, we do bring out the question, well, if we don't need it now, why do we need it in the future? And I think, as we're coming out of the COVID years, it's important to me to try and explain to people that, though, especially that initial, 12 to 15 months when things were changing so rapidly, that we have to remember that we were making decisions in real time with ever-changing information, and that we were saying at certain points, yeah, we know this is not ideal, but we are trying to protect a general population here, and so we're going to make some exceptions. And I think it would be a mistake to not point out to people that we're no longer in that situation, and therefore we should really try to move back to evidence-based best practices, which would be routine care for all our patients.
Gwyneth, in our last episode, we talked a lot about infant and childhood vaccines. And so now as we move into the adolescents, as you think about, the 10, 12, 13-year-old, pre-adolescent, adolescent, what are the relevant vaccines issues in that adolescent age group?
There's a lot less, which most adolescents are delighted to hear. There's a lot fewer shots when you're once you reach the tween years. So the standard vaccines that we offer at about 10 or 11 years of age are what's called Tdap, or it's a booster for tetanus, diphtheria, and pertussis. Or pertussis is whooping cough. We also offer a meningitis vaccine that covers 4 strains, A, C, W, and Y. That's a 2-dose series that's given at the around 11-year visit, and then you get your second dose around 16 years of age. And then there's a second meningitis vaccine that's specific for meningitis B, which is the more well-known and more deadly of the meningitis infections. That is given also as a 2-dose series at age 16 and 17, typically, as kids are going off to college, which is when they're at highest risk for that particular infection.
So Gwyneth, why the emphasis on meningitis in this age group? What's unique about adolescents that puts them at risk for potentially life-threatening meningitis?
It's a good question. They start spending time in away from their home and in close quarters with others. So summer camps, boarding schools, colleges, areas where meningitis can spread very rapidly, is why we target those age groups. And then the other vaccine series that we offer to the adolescent population is the human papillomavirus, otherwise known as Gardasil, that protects against 9 different strains of HPV and aims to protect patients against various forms of cervical and penile cancers.
Sure. Yeah,
well, lest we be accused of shying away from controversy.
Yeah.
We would never want that here on Dr.
We would never want to do that.
Get into the main dish.
Yeah,
here we go.
Let's unwrap the HPV, because I know
a lot of stuff.
Andrew and I both get bombarded, as I know you do, from well-meaning and very concerned parents.
Yeah.
What should my decision be on the HPV vaccine? I struggle with that answer sometimes. So let's help listeners gain some understanding there, Gwyneth.
Sure, absolutely. Yeah, this is something I obviously get a lot of questions about also. I do tell people that it is a vaccine that I recommend to all of my patients. And I recommend it at the ages that it's, initially offered between the 9 and 11-year visit. I think that it gets people very nervous because human papillomavirus is an infection that is transmitted through sexual activity. And most parents, myself included, do not want to think about 9 to 11-year-old children being at risk for a sexually transmitted disease.
Right.
And there's a couple things that I like to point out to patients or parents, really, when we talk about this. First off, the reason we offer it as young as we do is twofold. One, as no one listening to this podcast will be surprised to hear, we live in a fallen world, and some terrible things happen to very young children. Two, some very young young teen adolescents make the choice to become sexually active, and while I wish that wasn't the case, the data is very strong on that. And so the idea is to get this protection on board before that activity begins. But the other, and I think actually more convincing piece of information that persuades me to offer it to this young age group is that just as adolescents are going through an incredible growth, a physical growth and development, the immune system in this age group is also going through remarkable changes. And there is a window of opportunity in which we can actually induce a stronger, longer, more effective response in the younger age group than we can once that immune system has kind of finished its growth spurt. Such that if you complete the HPV series before the age of 15, you actually only need 2 doses. If you receive the series after the age of 15, you require 3 different doses to get to the same efficacy and duration.
Yeah, I mean, as a gynecologist, I see young women only, obviously, and it is a struggle. I mean, especially a lot of my patients would classify themselves, I think, as authentically Catholic, and they're thinking, I'm raising my daughter that she is going to have sexual relations with one man, and it will be her husband. And assuming he's been raised in a similar family, the HPV vaccine is obsolete. And I want to say that's exactly correct. But then there's the biology side of me that's saying, well, your daughter may fall in love with someone who had a colorful past, who's now a wonderful person, but maybe they had.
Well, this is exactly this is exactly how I approach it. I agree with everything you just said. I think we are all doing the best we can to teach our children a sexual ethics and morality that would lead them to wait until marriage to become sexually active. But again, in this fallen world that we're all living in, the numbers are what the numbers are. And when it came to making the decision for my own children, I had to reckon with the fact that I have no idea, first of all, if he's called to marriage, but second of all, who his future spouse may be. And what if my son is the one to bring that person into the church? What if they are the one to, cause a conversion? And do I want him to be at risk for a disease that may have been contracted 10 years before they ever met?
Sure.
And I do tell parents, I said, look, you can go to confession, you can have all sorts of not all sorts, you can have all your sins forgiven, including any sexual sins that you may have committed, but that absolution, while it cleans your soul, it cannot do anything about the HPV virus living within you.
That's a good point.
So those are the biological realities of being human, of having a human body post-fall. So that's how I try and explain it.
I think also we're seeing a time where, strangely enough for gynecology, the pap smear is sort of becoming obsolete.
Yeah. Because
cervical abnormalities are HPV abnormalities. If you take HPV out of the picture, for the most part, the pap smear sort of culture, you might say, almost goes away. And now there's newer recommendations that say, don't do a pap smear, just do an HPV test.
Yeah, the HPV test.
And so I sort of use that in my mind as a way to say, it sort of makes the HPV vaccine maybe seem more relevant. But I appreciate that insight. What kind of things do you hear from parents about the vaccine?
I mean, with all vaccines in general, but, HPV, for the reasons we're discussing, is looked at slightly differently because there's a behavior involved. There's always the question about side effects, right, and bad things. And I'm sure a cursory Google search of HPV and bad outcome would yield mountains of YouTube videos. Do you have any comments about that, or in your experience, have you seen or heard anything regarding that?
I've heard lots of concerns, for sure. I think, interestingly, as time marches on, I've been in practice almost 15 years now. I actually hear those kind of concerns less and less. And I think as this vaccine becomes something that now the parents of my patients were offered, because it's been around since, it was initially approved in 2006 and the current version in 2009. People are more and more confident. I think, as we saw with COVID, anytime there's a new vaccine, people are probably appropriately a little nervous, and they want to see the data. The question I get most frequently about potential bad outcomes from HPV is the question of causing premature ovarian failure in young women.
That's right.
Somehow that caught fire somewhere, 5 or 10 years ago, that this was inducing some kind of premature collapse of fertility for young women. And I just reassure them for that, the data just does not play that out. And it's all the same conversations and explanations that we had on the last podcast when we were talking about vaccines for the younger age group, that you have to look at how the data was collected. You have to go over the concept that causation and
correlation,
coincidence are not the same thing. Yeah.
But I think you remind us, I think, Gwyneth, too. I mean, it's hard to get in a nice capsulated statement, but all of us can remember the controversy over the COVID vaccine. And what I find myself wanting to point out is HPV and Tdap and those historical vaccines didn't come onto the scene in the midst of a worldwide pandemic.
Right.
When the process was incredibly rushed, emotionally and politically charged. I think one of the side effects, pun intended, of the pandemic has been now we have sort of a jaded look at all things vaccine. Whereas a jaded look at the COVID vaccine is probably justifiable, but don't lump it in with all of the others.
Yeah, it's easy to throw the baby out with the bathwater, right?
That's right.
Even though we're talking about adolescents.
Yeah.
But
and with that horrible analogy, we should probably step away for a break. We'll be right back with all things adolescent medicine right after the break here on Dr. Doctor.
And we are back on Dr. Doctor, talking to Dr. Gwyneth Spaeder. Thank you for coming on. We're talking about adolescent visits. And we got to cover the HPV vaccine, which is a big one. But kind of even a more general topic that I've always had kind of questions about myself. In medical school training, when they're talking about adolescents, there's always this discussion about having the parents leave the room to try and talk to the patient, the child, on their own. And a lot of times it's different ages when this practice starts, but I think the general thought is they might reveal something to you that they are keeping from their parents.
And if you're parents, if you're not expecting this, it could be a bit unnerving, maybe even off-putting.
Oh, yeah.
Unless the practice has a way of warning you this is coming, maybe at the next visit or something.
Well, I guess, Gwyneth, how do you deal with that? How does it work in your practice? What are your thoughts?
Yeah, it's a great question. Certainly that's how we were all trained and encouraged to practice. And I think you're exactly right. The thought is, and it's probably an accurate thought for many of the adolescent patients, that they will be willing to discuss things with you that they might not be willing to discuss with their parents in the room. So this is how I approach it. First of all, I think this very much depends on the age and maturity level of your child. So this is one of the many reasons we encourage people to develop a relationship with their pediatrician over time. This should be someone you know well, so that you have some trust in them, and it allows us as the pediatrician to know you, your child, your family, and be better able to assess when and if a private conversation with the patient might be appropriate. But I also say that parents should never feel that they have to leave. And if they are not comfortable with leaving, and their child is under the age of 18, then they don't have to leave. And I've never forced a parent to leave an exam room. But I do encourage it at a certain point. And for me, I find that typically starts, 15, 16-ish, like sophomore, junior in high school, to allow the patient to have that time just with me, for a couple of reasons. One, sometimes they are more forthcoming about some risky behaviors when they're just talking with me. But two, as we mentioned earlier in the show, I want them to start experiencing taking ownership of their own health, and their own health care. And if mom or dad is in the room, the default is always to let mom or dad answer the questions.
Yeah.
And kids need to have that practice in a safe setting, kind of advocating for themselves, listening to the questions, giving appropriate responses. It's part of learning how to adult.
I guess one of the questions I think parents would have, maybe I've had conversations regarding, what if they reveal something that you wish the parents would know, or you feel like we need to encourage this kid, I'm not going to see you for another year. This sounds like a 4-alarm fire, and mom doesn't know. What's my role as the doctor, and how can I facilitate that?
So it's a great question. I do always tell my adolescent patients, if I'm speaking to them one-on-one, that I will maintain confidentiality unless I believe that what they have told me places their health or life at significant risk, or the health or life of another individual at significant risk. And then I will bring the parent back into the conversation. So the patient knows that up front, and they can factor that into whatever they're willing to share with me. But even if it's not that dire, I do really, in those conversations, both with the parent in the room and with the parent out of the room, encourage honesty and open communication between parent and child. It's sometimes very hard, and I think we can all remember back to our own adolescent years, to understand the enormity of a parent's love, right? And so it's hard to convey to a scared teenager that their parents really, really do want the best for them and want to work with them through this. But sometimes hearing it from an outsider like myself, they're more willing to believe it than hearing it from mom or dad.
And I wonder, too, to what degree this has become sort of a triggering topic with parents.
Yeah.
With so much talk about parental rights, whether it's before school boards or, with issues of gender dysphoria and the schools or other sort of municipalities or authorities interacting with children outside of the parental relationship, parents may feel put upon and attacked and thinking, well, this is just one more affront, you might say, to kind of parental rights.
I completely understand that. I completely understand that, both as a pediatrician and especially as a parent, right. Because it does seem that parental rights are under attack, and people have very good reasons to be concerned about that. So another aspect of this that may be helpful for parents to hear, at least in terms of how I approach it, is I actually try to do my counseling about kind of hot button topics: sexual activity, illicit substances, smoking, vaping, texting, driving, all of the scary stuff for parents about raising teenagers. I do that with the parent and the child in the room. So the parent knows my stand on these things prior to being asked to leave their child with me. And hopefully that provides some reassurance to them that I'm not, not trying to sneak some message in under their nose. And as I said, I don't require parents to leave. So if they're not comfortable with it, then by all means they should stay.
It sounds like there's a big importance of knowing your pediatrician and trusting them.
One more piece of evidence for longitudinal relationships with your healthcare providers. The scenario that I see commonly is, an adolescent young woman and a very concerned mother, rightfully so, and the mother is doing all the talking, and the daughter is quite happy to have the mother do all, as you mentioned. And so I like to say to the mother, it would really help me if I could hear from the daughter's name. I know that you can tell me, but I'd really love to hear from the daughter. And then sometimes I'll say, would it make that easier maybe if if we sort of broke up our meeting here for part of it and then just sort of watch the reaction. But I really love the way that you said that. You sort of put your credentials out there, so to speak, in front of
I
the
show my
parents.
cards.
Yeah.
I do. I mean, this is their child, and
Right.
hopefully, I'm always acting in the best interest of their child. I believe I am, but
Yeah.
they have to have the trust and the belief in that to feel comfortable to leave me alone with them.
Well, and you had mentioned counseling on hot button topics. I feel like there's so many in adolescence, but especially, progressing over the last 5-10 years, especially, it's the sexual ethics in adolescence. How in the world do you begin to broach that with, some little 12-year-old you've been seeing since they were born?
So yeah, it's one of those things that I know we're all aware is changing, almost more rapidly than you can believe. This was not something that was covered at all in my pediatric training
Right,
18 years ago. It just didn't exist. I vaguely remember hearing about it in my psychiatry courses, but it certainly wasn't a part of pediatric practice, but it is today. I live where I live, and where I practice, it has not been something I encounter on a regular or frequent basis. Right. But it certainly is something that's always on everyone's minds, for one reason or another. So, what I do, kind of starting in the early tween years, which I would define as, 11-ish, is, and maybe for some girls, depending on, what I see in their physical exam even earlier, I will just kind of generally ask, are there any questions that you have for me about how your body might be changing over the next couple of years? Are there any questions you have for me about how some of your friends' bodies are changing already? Because, there's just such an enormous range of normal when it comes to when puberty starts for both boys and girls. And so, in those middle school ages, you can have kids who, are completely prepubertal, in class with kids who are basically adult in terms of their sexual characteristics, and that can be really confusing for kids. So I like to give them the opportunity to ask questions, in a safe environment. I do start screening for sexual activity once kids hit high school, because unfortunately we know that that's a reality in the world we live in. I just ask them the question, have you engaged in any form of sexual activity? And if they say yes, then we have a conversation about whether or not they're using any form of protection, because I need to know whether they require, sexual transmitted infection screening, which I would offer to anyone who is sexually active. And I make sure that both sexes, but particularly my adolescent girls, understand that you can have asymptomatic sexual infections that you may not know about if we don't test for it, but can cause long-term harm to your fertility. So that it is important, from a purely health perspective, to screen for these infections if you're choosing those kind of behaviors and activities.
Well, as a fertility worker, I thank you for that. I hope all of your colleagues are doing the same thing. It would be horrible for us to be accused of letting you off easy. So, but, I had a question recently from a mother who said, I'm pretty sure my daughter, who is young, is sexually active. And she says to me, what do you think about that? And so, my tough question to you, Gwyneth, is how do you address your views as a mother, as a parent, as a Catholic, with maybe the American Academy of Pediatrics' views on these topics? How do you make that work in a way that you stay sane?
Am I sane? I hope I'm still sane. Yeah, I mean, it's a difficult line to walk, isn't it? From a professional, spiritual, personal standpoints. So I guess what I would say to that parent, what do I think about that? I honestly believe it is not in the best interest of the child's health to be sexually active at that age. And that is for both biological and emotional reasons. That there are inherent risks, physically speaking, to sexual activity, and that there are emotional realities to that kind of behavior and relationship that can be very damaging to young people. And so I do my best to encourage my patients, whatever their faith and moral background, to not become sexually active at such a young age. I don't know if that's answering your question.
It is. I mean, I think we all struggle with that. I mean, I like to say there's the theological road and the biological road. They end in the same place.
Yeah.
Which road would you like to hear about? And then I had a disgruntled parent once say to me, "Well, you think that because you're a Catholic." And I thought, no, I mean, I think that because I'm almost 60 and I've lived a lot. And to your point, this is bad for you. Outside of moral theology. Yeah.
I've found a place that always stresses me out a little bit is when maybe a patient and her mother especially may have drastically different worldviews, still seeking out care with me, but you may have found yourself in a position before where they're in for a well child check. The young lady is maybe 15, and it's very clear, however they come out and say it, is, okay, we got to get her on the pill now. Yeah. How do you deal with those conversations when the expectation is so heavy? In my practice, a lot of times we're very upfront with, I'm blessed to be in a Catholic place, so we just don't do that. I kind of take the easy way out. I think it's a lot harder to really engage on the folks who don't necessarily see that conversation coming. How should we think about that?
Yeah, again, it requires careful thought and some finesse. So I not infrequently have either the patient or the parent or both asking me for some form of birth control, and my explanation or kind of response to that is that it's just not part of my practice. And if they ask me why, then I will explain that I don't think it's in their best interest to be sexually active at this age. I do use occasionally some hormonal birth control for non-sexually active adolescents with various gynecological problems in the short term. But if I have any reason to believe that they are asking for birth control as birth control, then I just explain to them that I don't provide that service.
But it's not an easy discussion. It's not an easy path. That it's tougher for you because the expectation, I think, is so high with specialty organizations and the like.
Oh yeah.
Sort of promoting. I get things from ACOG that say I'm supposed to be talking to 11 and 12-year-olds about IUDs.
Good grief.
And there's just a lot of pressure.
Yeah, it keeps coming, and we have various competencies and quality metrics we're supposed to hit and all this kind of stuff. So there is a lot of outside pressure, and there is a very firm belief in kind of more secular professional organizations that not only is it a possibility that adolescent patients will be sexually active, but in some sense that they should be, which again is something that I feel like has changed over the 10 to 15 years that I've been in practice. And I find that very discouraging and just very unfair to our young people that kind of pressure and expectation is being put on them by people that they should be able to look to as trusted authorities.
Everybody agrees they can't consent to alcohol or tobacco use, but we expect them to consent to these sexual decisions. And then the whole transgender thing in general. I mean, and I guess maybe as I'm thinking of our listeners as a parent who don't have the option to come and see you, what are their children probably getting from their pediatrician in regard to questions about sexual activity? And I mean, I'm thinking of my oldest is going to turn 12 here in a month, and if a pediatrician asked him some of these, kind of, they're all leading questions regarding transgender stuff. I don't know what he would do. He'd be shocked, just flabbergasted, in many ways so unnatural. And we're homeschooled, so it still looks unnatural to him. What can parents expect?
So I think parents, if you don't know anything about kind of your pediatrician's background or kind of moral foundation or background, it would be considered fairly standard of care these days to start asking children probably around 12, 13, maybe earlier, are they interested in sexual activity? Have they participated in any forms of sexual activity? Do they feel attracted to people of the opposite sex, to the same sex, both? Are they comfortable in being identified as a boy or being identified as a girl? How I try to explain it to parents who, hear things that their children are saying and discussing among their friends, is that this is just an incredibly difficult landscape for these kids to be navigating right now. And I think for many of my patients, even those from families where, this entire topic was unheard of a few years ago, there's an incredible pressure in school. We haven't even talked about social media, on all these tech devices, to identify as something. And we have to remember that adolescence is supposed to be a time of finding your own identity, becoming your own person. But it's at the same time, also when they're starting to move a little bit away from the family unit and are looking for a community and to be accepted by their peers. And that's a very dangerous combination to be throwing kids out into the secular culture that we have today. So what I'm finding is that I have these patients who will say things like, well, I think I'm non-binary. Okay, let's talk about that. What does that mean to you? And as far as I can make out, in many cases, if not most cases, it's kind of a safe label for them to take because it's very non-committal. It basically means, especially for these sweet little middle schoolers who really want nothing to do with this, that they can just hang out with their friends, right? Like they like hanging out with their girlfriends, or they like hanging out with their, you're not required, it doesn't require you to do anything, but it allows you to claim a label that's considered acceptable within this community that has become so popular. And so I suspect that a large number of non-binary adolescents are just using that label as safe cover. The other thing I like to point out to kids when this comes up, particularly the younger kind of middle school age group, we in our modern culture keep pushing sex and sexual questions and sexual identity down on younger and younger age groups. And it's just obviously not developmentally appropriate. It should not be on their radar, right? Like they are not, they shouldn't be thinking these things or asking themselves these questions. And so I think what sometimes happens is you have, a sweet little 10 or 11-year-old girl who is like, well, I don't like the boys in my class. They're gross. And therefore, because I don't like boys, I must be gay. Yeah. And what I try to introduce into the conversation is, no, you think boys are gross because 10 and 11-year-old boys are gross. They are gross. You have to give them some time. Like, you don't actually have to make this decision right now. So again, it's just what we've done to this age group and as a culture is really sad, right? Like, this is just not something you're supposed to have to think about at 10, 11, and 12 years of age.
You remind me of a psychiatry mentor that I had who was giving a lecture, and he was describing that a parent said, I think my 8-year-old is a homosexual. And he said, no, your 8-year-old is asexual.
Yeah, exactly.
Right? And they'll remain that way naturally unless something forces them. And it reminds me when you say that, when you say they shouldn't be thinking these things, I think it's fair to say you say that not as in a normative kind of moral way. It's because if left to their own devices, they wouldn't
Correct.
be thinking about those
They
things.
wouldn't be thinking.
Right.
Yeah, I'm not passing a moral judgment like it's bad that they're thinking about these things. I think it's just not developmentally natural for those questions to arise in those age groups.
Yeah, I think about my own 14-year-old son who is interested in two things and two things only: food and how many push-ups he can do.
There you go.
And left alone, I think he'll stay that way for a while. But there's so
For a
many
while,
external forces that are trying to force these things on our kids. It is frustrating.
Gwyneth, I guess one kind of a tangential thing, a little bit related, is what do you do when you have a patient, a teenager, and their parent who disagree about something? Could be sexual morality, could be vaccines, you name it. How do you navigate that as a doctor?
Yeah, I mean, in some ways, it depends on the laws of your state. So different states have different laws and ages of consent for a variety of things, for a variety of ages, whether it's vaccines, what age you can consent to vaccines, what age you can seek health care under, for sexual problems or concerns without parental consent. So, but if they're both in my office disagreeing about something together, then I just feel like my role is to try and be the neutral kind of party, providing outside guidance. Even something as simple as social media use, or when they get their first smartphone. A lot of kids disagree with their parents about those kind of decisions. And I think sometimes just having someone who's not emotionally kind of tied into the relationship to provide, some thoughts can be helpful. For the most part, I think sometimes I disappoint my patients because I tend to agree with their parents on the restrictions of social media, smartphones. But I think the best thing that can be done in that scenario is just to continue the dialogue and to provide whatever objective data might be missing from the conversation about whatever it is they're disagreeing on.
As you think about these adolescent years, whether it's with boys and with girls, recognizing it could be different issues, but what comes to mind in your practice as sort of that most important thing that you're looking for, that if you didn't find but one thing, that's the thing that you would find?
I think what I kind of intuitively screen for as I'm sitting with an adolescent and their parent in the office is kind of their sense of self-ownership, and their sense of kind of peace within themselves. And that's a wordy way of getting at the question of mental health, which we haven't spent a lot of time talking about. But it's very clear from a way an adolescent conducts themselves within a well-child check how they're doing in terms of social interactions with their parents, with adults, with their peers, how they're performing in school, and how that's likely to play out in the next few years as they move towards more independent living. So I try to kind of always be on the lookout for warning signs or concerning signs. To me, that's inability to answer questions themselves, inability to put their phones down during the appointment, kind of short, rude answers to parents. All adolescents get a little snarky with their parents, but when they do it in front of another adult, that's a little bit of a warning sign to me. So those kind of things, because those are things that parents might not necessarily think we have anything to offer them. But I think the pediatrician can be useful in those scenarios to say, hey, I've noticed this, I have these concerns, and I'm here to say it's okay to kind of challenge your child to, one, explain why they're feeling this way, how can we work through this as a family, but set the bar high. I think if I can do anything for my adolescent patients and their parents is don't give in to this secular culture's lowering of the bar for behavior and expectations for this age group. They can do great things. They can be responsible individuals. They can make good choices. We're just constantly telling them they can't. And then we're surprised when they don't. So, I try to encourage parents to parent still through these years. They are not little adults. They're not adults at all. They still need their parents. And it's okay to really challenge them to be great people.
Well, Gwyneth, that seems like the perfect place to leave this latest installment of Pediatrics and Adolescent Medicine with you. Thank you again for joining us and for sharing your expertise here on Dr. Doctor.
Oh, it's always a pleasure to talk with you guys. Thank you so much.
Well, welcome back to Dr. Doctor. And Andrew, I think this has been a great discussion. I think all parents are really probably happy they tuned into this one.
Well, it's a stressful situation having teenagers to begin with. Going to the doctors provokes stress on its own, and when you put them together, it's dangerous. But I was so happy to have Gwyneth on to walk us through it. I felt like I learned a lot, too.
My first of my top 3 takeaway, I think this idea that who you choose as your peds provider, be it a family physician or a pediatrician, it matters.
Yeah.
And so know about them, know their positions on life and on parenting and on important moral and ethical questions. You need to know that.
Yeah, I think one of my takeaways would be good advice to me as a doctor. Get your credentials, your advice out there with the parent such that if they choose to leave the room or if that's part of your exam, it shouldn't be a stressful process because you're not going to spring anything on them. You already got the really heavy stuff out with the parent in the room.
And if you as a parent have those doubts in that setting, maybe number 1 wasn't right. Maybe you didn't choose properly.
That's right.
Yeah. I really loved that she finished with probably the most important thing in an adolescent medicine, you might say, is their mental health, for lack of a better phrase. I mean, how are they doing emotionally? Is there depression? Is there anxiety? Is there sort of maladjustment with society and friends? That's so important in those years.
There's an unlimited number of things we could talk about. I expect that we're going to be covering this in the future as well, and especially in our daily lives. I'm happy to have had this conversation with her.
Yeah, me as well. Well, listeners, thank you for joining us for another episode of Dr. Doctor. You can check out all of our old episodes at our website, drdoctor.org. You can just click on Episode Archive. You can look up over 300 episodes if you'd like.
We have a video version of our podcast. Just click on the YouTube link near the top of the homepage at drdoctor.org and click Submit a Question if you have a great idea for an episode.
This is Dr. Chris Stroud.
And Dr. Andrew Mullally, and we're signing off until your next dose of Dr. Doctor.